Hello everyone, my name is Faisal Al and I'm one of the second year residents in our program. First of all, I would like to congratulate each of you for this significant achievement. You are starting one of the most exciting parts of your professional life, and we in the intern welcoming committee are more than happy to help all of you guys in making this process as easy as possible. Welcome to Creighton family. And what I have here is a couple of slides about discharge planning that I think is very important topic. It was confusing and difficult for me, especially in my first few months of my internship. And actually, I didn't understand it fully until the last few months of the internship. It's a very important topic. It will be part of your daily routine during the hospital, especially in the hospital medicine rotation, but it will be also in other rotations that you will have, and I will try to simplify it as much as I can in like 10 to 15 minutes. So, what is discharge planning? Discharge planning is the process of preparing the patient for safe and appropriate discharge and arranging for his care after he leaves the hospital. As we all know, hospital is not the best environment for the patient. It increases the risk. Prolonged hospital stay will increase the risk of infections, will increase the expenses on the patient, will increase the expenses of the institution or the hospital, and it make the life of the residents and the interns difficult because it will increase the patient list, and this will make you see more patients, and it will make your life difficult. So it is always ideal to prepare for the discharge of the patient ahead of time and find a good placement for the patient from the very beginning. So they noted that improvement in discharge planning will decrease the rate of the readmissions because the patient will be in appropriate placement that will take care of him instead of coming back to the hospital, and will reduce the length of stay. And it is exactly like in the airplanes. The most critical part of the flight is the takeoff and landing. This is the time where most of the events and accidents happen. It's exactly the same with the patient, with the admission and discharge the patient. The admission and discharge are the most critical times, or the times for the most of the medical errors to happen. And so discharge planning, or the plan for discharge, should be started or should start we should start think about the discharge plan for the patient, or the disposition of the patient from the very beginning, or the very first day of the admission. We must think about the expected duration of stay during admitting the patient by knowing the principal problem and how long it will take for the patient to be able for him to be ready for discharge. And this should be arranged according to the severity and to the type of the medical condition that the patient is suffering from. Now, the medicine nowadays is multidisciplinary team. You are not alone. You have a team, and you have a lot of resources in your facility. You have to utilize all of these resources. You have to communicate with your team. So it is multidisciplinary process that involves the primary team, which includes you and the rest of your team, social workers, case managers, the other services like physical therapy, occupational therapy, other consultation specialties that are involved in the patient care, and many others. So this is very important. You have to know what's the resources available in your facility, and you have to try to utilize it to the max. Try always, when you when you are on the HMS rotation, to communicate with the social workers and understand on daily basis, and understand their plan for the patient, where they think the patient is going, and what's the difficulties that they are encountering in discharging the patient, or in arranging for a good disposition for the patient. This includes the economical and logistic barriers or obstacles that might face the patient. also try to communicate with the occupational therapy and the physical therapy and ask them about the ability of the patient or the safety for the patient to go home. Check with their daily recommendation about the abilities of the patient or the readiness for the patient to be discharged, the safety of discharging the patient home, or if the patient needs some sort of short-term rehab or nursing, skilled nursing facility as a disposition for the discharge. So what are the options that we have for discharging the patient? The options that we really have are multiple and more than what's listed here in this slide, but I tried to highlight only the most important destinations or options that we have, and that you will hear about it more frequent than others, and you will be discharging the patient to these destinations. So the first option that we have is the home health care. Then we have short-term rehab, long-term acute care facility or the LTAC, assisted living facility, skilled nursing facility, and hospice. There are a couple of other options that I'll try to mention, but these are the main options that you have. The patient has the right to choose, and this is guaranteed for all the patients in the American Constitution. Every patient has the right to freely choose which provider will provide his medical care, and this includes the institution, the agency, the person, and which is guaranteed by the Medicaid program. The first option that we have, and I will talk about, is home health care. It is a wide range of services or health services that is provided at home. So the patient will be at home, and the healthcare personnel will be approaching the patient at his home and providing the medical care there. It is a smart way. It's less expensive. It's more convenient for the patients, and it is just as effective as the hospital care or skilled nursing facility. We can use or utilize this option by, especially when we want to discharge the patient home while he's on IV medication. So we can send the patient home, and the nurse will come on daily basis and give the patient the required IV medication. They can do the daily dressing or every other day dressing. They can take care of their decubitus ulcers. They can provide some sort of physical therapy or occupational therapy, provide some education to the patient or the caregivers, or they might go and assist the living situation for the patient. This option must be ordered by physician, and for the patient to be qualified for home health care, he need to be homebound. By homebound, I mean that the patient is not able to reach to the outpatient clinic or outpatient facility to receive this care, like IV medication or the physical therapy. The patient can leave home to go, for example, to get his food, but he need to be unable to go to the to reach the health services or the outpatient health services. The second option that we have is the short-term rehabilitation, and it is appropriate for the patients who have who need rehabilitation for short periods of time that's less than 3 months, and it is mainly for the patients with acute injury, acute trauma, acute illness, like that needs to be needs short term of rehabilitation and physical therapy. And we have two options for that. We have the acute rehabilitation and the subacute rehabilitation, and the difference between two is mainly in the duration that we'll talk about it in the next few minutes. The acute rehab, it provides the rehabilitation services like physical therapy, occupational therapy, speech therapy. It is more intensive, and it provides at least 3 hours of therapy per day, and this up to 6 days a week. Usually the duration is less than 3 months, and there will be usually an attending physician on site who can manage the acute medical events or the medical needs of the patient. The subacute rehabilitation is pretty much the same. The only difference is in the duration. So it will be around 1 to 2 hours a day, less than 3 hours a day of the rehabilitation services, and it will be also up to 6 days a week. The other option that we have is the long-term acute care facility, and this is a kind of specialty care hospital. It's a kind of hospital that provides that provides care for some serious medical problems that is for a prolonged period of time. So we can't keep the patient for 1 month in the hospital. Let's say the patient needs ventilator, or he is on ventilator, and we couldn't wean him, or we can't wean him off, but he's stable in other medical conditions. I mean, he's stable. He doesn't have any acute infection or acute electrolyte abnormality or any other acute event. So we can discharge the patient to the LTAC, the long-term acute care facility, where he will be seen by physicians and he will get the appropriate care similar to the hospital, but this will decrease the load on the hospitals. Under Medicare, the patient must need at least 25 days of hospitalization to qualify to be discharged to long-term acute care facility. Sorry. The services that can be or the patients that can be seen in LTAC, as I mentioned, the ventilator patients who doesn't have acute problems, patients on ongoing dialysis, intensive respiratory care, patient with complex medication that can't be given, especially if it's IV, and can't be given at home. Those who need extensive wound care, or parents, and they are staying for a long time. That's why in the hospital, that's the optimal patient, or the type of patients that you will see in the LTAC. The next option that we have is the assisted living facility, and it is a system of housing facilities that actually just provide some sort of assistance to the patients who can't take care of their basic needs. So they will help the patient making his food, dressing, grooming, having their basic needs. And they might provide them some, like, give them their medication on time and the stuff, but they will not provide more complex medical services. That's the idea of assisted living. It is different from the skilled nursing facility, which is actually nursing care. They provide some sort of nursing and rehabilitation to the patients, and it is usually some sort of temporary process. It's not for long term. It will stay like for a couple of months, where the patient will need some sort of rehabilitation and intensive and help with their medication, help with their daily activities and daily needs. The patient need to be qualified for this, and you have to ask the patient, your social worker, and in order to help you with the with knowing if the patient is qualified or not. They have their own criteria, and they will tell you if the patient needs or qualify for SNF or not. Medicare doesn't cover custodial care, so if the patient needs custodial care and he doesn't have chronic medical issues and he doesn't qualify to SNF, the patient, unfortunately, he will not qualify for skilled nursing facility, and this will not be appropriate option. I wrote here some of the important examples that you will hear about it while you are in, that's available in Omaha, and you'll hear about it frequently while you are discharging your patients. So we have options like Douglas County Health Center, Ridgecrest Rehabilitation Center, and many other options that's listed here. Try to familiarize yourself with the names, because sometimes it gets confusing, and in order to know exactly what's going on around you and what the social worker and the other team members talking about. What's the difference between the SNF and the the assisted living facility? Is mainly that the SNF is temporary in nature. It's intended to prepare the resident to return to their independent apartment, while in assisted living, it's usually the patient is unable to take care of himself, so you need to just provide him with the assistance and the basic life and basic needs, like bathing, dressing, grooming, and help with medication and with meal preparation. So here's summary of the options that we have for the patients. The patient can be living alone, and he's completely completely independent, taking care of himself, and this is we can discharge him, like we will have the option like home and or self-care. some patients need some home care. Someone is visiting them at home to help them in making their food, or taking care of themselves while they are at home. This is a little bit different from the assisted living, where the patient will be in an institution that's taking care of their basic needs. Um, there is patients who have dementia and memory issues. There is another option that's called assisted living memory support, where they care about these patients who have uh, problems with memory, and they have special programs or care plans for them. There is the skilled nursing facility or the nursing home, where there will be complex medical needs, or the patients have complex medical needs, and they require 24 hours 7 nursing care. There is another term that you'll hear about it frequently, and you need to understand it, which is the concept of hospice. So the hospice, it is a place where the patient, or it is a concept where the patient is terminally ill, he is approaching his end of life, and he has a terminal disease that there is no cure of it, or the cure is not expected, like end stage cancer, end stage heart failure, end stage COPD, and these problems that the patient is, we don't expect his cure, and he doesn't expect that, and he just need to live his last few days of his life with his family, with trying to be more comfortable, have a better quality of life, and have dignity, and to be free of pain. That's the basic idea of hospice. This can be provided at home, or can be discharged to a hospice facility that provides the comfort care and the hospice care. Um, some other names that you might hear about it, and actually this was mainly when we were in Creighton University Medical Center. Now, when we moved to Bergen Mercy, the patient population changed, and we hear about these things much less than when we were in Creighton. But you might still admit one of the patients who are homeless or who have psychiatric issues. So these are some of the common names: Sienna Francis House, Open Door Mission, New Visions. All of these are homeless shelters. Usually, we don't prefer to discharge the patients to these places, because usually it's a kind of just provides them with it's a shelter, so just place where they can sleep, or they have some food, but there is no support or no assistance with their medications or with the other stuff. We usually try to discharge if the patient is qualifying for SNF or assisted living. We usually try to discharge the patient to those places. Psychiatric facility, you will hear about lasting hope frequently while you are admitting the patient or discharging them. So some of the patients, they are ready for discharge, but the only issue is just transportation, and you can't imagine how this can delay the discharge. The patient can stay in the hospital for 1 or 2 days just in order to find appropriate transportation, and we can help with that. We can provide either direct transportation or cab voucher. You just need to talk to communicate with the social worker, and they will arrange that for you. That's all what I have for you guys here. I hope this will help you and make the HMS rotations easier for you. And thank you very much, guys, for listening, um, uh, and have a good day.